I'm Anthony Elias, Professor of Medical Oncology at the University of Colorado Cancer Center, and have been doing breast cancer research for 30 years. So today I reviewed the major abstracts from ASCO22 on metastatic breast cancer. And I picked 5 abstracts, 3 of which are basically watch this space because it's going to probably affect therapy tomorrow, and 2 abstracts that are game-changing today. The first abstract was on Elias, which is an oral SERD, and the phase 3 trial has actually been presented and published. This was an update of the trial, the Emerald trial, which demonstrated that the oral SERD was superior to fulvestrant or aromatase inhibitor in the third-line endocrine therapy setting. The abstract was an update of the 80% of the population that had no prior chemotherapy, and showed basically the same results as the original trial. Elias and other oral SERDs are likely to get approved by the FDA in the next number of months or year, and will certainly change the scope of endocrine therapy. The second abstract was on the Faxin trial, which was looking at capivasertib, which is an AKT inhibitor for AKT 1, 2, and 3. And this was being combined with fulvestrant and compared to fulvestrant alone in patients with estrogen receptor positive breast cancer. The findings were that there was an overall progression-free survival and overall survival in the patients receiving the capivasertib, but this was predominantly in patients who had mutations in the AKT PI3 kinase pathway. The third trial was the question of whether one should continue CDK4/6 inhibition after prior exposure to CDK4/6 inhibition in the first-line setting. So these were patients who had progressed predominantly on palbociclib, who were then had their endocrine therapy switched to either fulvestrant or exemestane, and then were randomized to receive ribociclib or not. This trial also demonstrated the benefit of ribociclib addition and therefore continuation of CDK4/6 inhibition into the second-line setting for ER-positive breast cancer. This was a randomized phase 2 and requires confirmation with the Capitello phase 3 trial, which is expected to be reported in the near future. The final 2 abstracts were game-changing. One was the Tropics O2 trial, which was sacituzumab govitecan versus treatment of physician's choice, or TPC, in heavily pretreated patients. So these patients had a median of 3 prior chemotherapy regimens. So this was given either in the 3rd or 4th or 5th line settings compared to the single-agent chemotherapy. Sacituzumab govitecan improved progression-free survival. There was a trend in terms of improvement in overall survival, but this did not meet statistical significance. This extends the use of sacituzumab into the ER-positive, HER2-negative patient population, and complements the previous ASCENT trial that was in the triple-negative breast cancer group. The final trial was the DESTINY-04 trial, comparing TDXD, otherwise known as trastuzumab deruxtecan, versus TPC in second-line therapy of metastatic ER-positive or triple-negative breast cancer. So this was in a group called HER2 low, which was defined as 1+ by IHC or 2+ IHC with negative-ish. This trial demonstrated a significant progression-free survival advantage and an overall survival advantage for this population with the use of T-DXd. Thus, today we would treat somebody in second or third line or beyond with T-DXd, and we also have the option of treating with sacituzumab. I did point out that the two may interact with each other, and the sequence of treatment may not be straightforward because both use a topo-1 inhibitor as the toxin. And therefore, resistance to topoisomerase I and inhibition may cause cross-resistance. The toxicities of the two antibody-drug conjugates are different, and it's particularly important to monitor for interstitial lung disease with the T-DXd because this toxicity can occasionally be fatal. Thank you for your attention.